A persistent frustration in modern assisted reproductive technology is the patient who fails to respond adequately to standard exogenous hormone stimulation. This microscopic view illustrates the clinical reality of diminished ovarian reserve, or DOR, and poor ovarian response, POR. In these patients, the ovary presents only a sparse number of resting follicles available for development, creating a severe roadblock to IVF success. For this specific population, simply increasing the dosage of conventional gonadotropins yields diminishing returns. The ovaries lack the functional capacity to process higher chemical loads into viable egg yields. The standard Western approach often defaults to administering more medication. However, addressing this bottleneck requires an intervention that improves the ovary's baseline receptivity, rather than forcing a response from a compromised system. Solving the DOR challenge requires looking outside standard pharmacological protocols. Clinicians must employ interventions that modulate the underlying endocrine environment before the stimulation phase even begins. Western medicine has traditionally viewed complementary therapies with skepticism. A common assumption is that modalities like acupuncture provide only subjective somatic stress relief, offering no measurable physiological benefit. A wave of rigorous, peer-reviewed data published between 2023 and 2025 contradicts this assumption directly, providing concrete evidence of physiological alteration. Clinics like the Berkeley Center for Reproductive Wellness in Manhattan have spent nearly 3 decades building an evidence-based approach, integrating complementary care with rigorous reproductive endocrinology. This split-screen flowchart illustrates their core treatment model. On the left is the linear, single-path, conventional ovarian hyperstimulation model. On the right is the integrative model. Here, acupuncture, light therapy, and customized supplementation are woven directly into the standard IVF timeline at multiple precise points. The clinical data reveals that adjunct acupuncture is a quantifiable intervention. It alters gonadal hormone regulation, improves oocyte yield, and increases embryo quality. To evaluate how this mechanism works in practice, we will map the latest meta-analyses directly across the chronological timeline of a standard IVF cycle. This master timeline represents a complete IVF cycle. We start here at Phase 1, baseline ovarian reserve. This is the physiological state of the patient's endocrine system before any exogenous hormones are introduced. A 2023 meta-analysis published in Frontiers in Endocrinology examined this exact phase. Encompassing 13 randomized controlled trials and 787 patients, the researchers measured specific reserve markers, comparing a control group to an acupuncture plus IVF group. Faster, analytical, looking at the negative markers, the treatment group recorded statistically significant decreases in baseline follicle-stimulating hormone, or FSH, levels. They also achieved a lowered FSH to LH ratio compared to the control group. At the same time, the data reveals simultaneous, measurable increases in anti-Mullerian hormone, or AMH, alongside a higher antral follicle count. The analysis noted a critical caveat regarding dosage. The researchers found high heterogeneity across the studies, indicating that the success of the intervention is heavily dependent on protocol intensity. Generating these strong physiological effects demands a high-intensity protocol, defined in the data as the precise stimulation of 10 or more specific acupoints per session. Applying this high-intensity protocol primes the ovarian environment. By lowering FSH and boosting baseline follicle counts, the ovaries become highly receptive to the hyperstimulation phase that follows. Advancing past the baseline, we enter the controlled ovarian hyperstimulation and retrieval phase. Moving the timeline forward to Phase 2, we turn to a network meta-analysis from the journal Medicine. Covering 15 trials and 1,195 women, this study breaks down outcomes by specific stimulation modality, branching into transcutaneous electrical acupoint stimulation, or TEAS, and manual acupuncture. The findings demonstrate that the chosen modality dictates the physical outcome. TEAS proved statistically superior for increasing total bulk metrics. Patients receiving electrical stimulation saw higher total oocyte retrieval volumes and overall antral follicle counts. However, the outcomes shift when examining manual stimulation. Manual acupuncture drives a distinct biological mechanism. Instead of sheer volume, it results in a higher yield of mature M2 oocytes, prioritizing cellular quality and readiness for fertilization. This distinction in the data proves that acupuncture is not a monolithic treatment. Clinicians can deploy specific modalities to precisely target either follicular recruitment with TIAS or oocyte maturation with manual stimulation, depending on the patient's specific deficit. During hyperstimulation, the effects of this intervention extend beyond the ovaries to the broader reproductive system. A related 2023 systemic review of 516 women examined the physical synergy that occurs when combining acupuncture with controlled ovarian hyperstimulation. The researchers recorded clear improvements in systemic hormonal markers. Compared to hyperstimulation alone, the combination therapy yielded higher estradiol levels and further depressed FSH. This schematic visualizes a crucial physical change driven by those hormones. The systemic review found a statistically significant improvement in endometrial thickness, creating a highly optimized uterine environment for implantation. Adjunct acupuncture acts as a systemic multiplier for conventional hyperstimulation. It optimizes both the seed, the follicle, and the soil, the endometrium. We now transition to the final and most critical phase of the cycle, post-retrieval embryogenesis. The ultimate test is whether these interventions actually result in better embryos in the lab, like the healthy cellular cleavage you see here. A definitive 2025 meta-analysis encompassing 18 distinct studies answers this question. Looking at this scatterplot, the 2025 data provides moderate certainty evidence of a direct association. Higher frequencies of acupuncture sessions correlate tightly with higher fertilization rates and a higher overall yield of high-quality embryos. A 2024 multi-center randomized trial corroborates this. They found that even in cases where total oocyte numbers did not drastically increase, the embryo cleavage rates were significantly higher in the treatment group. The 2025 data includes a vital caveat. These post-retrieval benefits are most notable in patients who initially presented with elevated baseline FSH and who completed a sufficient frequency of treatment sessions leading up to retrieval. The clinical impact of acupuncture does not stop at retrieval. The early metabolic and endocrine optimization improves the developmental competence of the resulting embryo. Pulling back to view the entire journey, the data forms a continuous chain of evidence. The intervention begins with baseline hormonal regulation, moves to targeted follicular maturation, provides systemic endometrial support, and results in improved final embryo cleavage. Broader umbrella reviews, such as a 2024 analysis in Frontiers in Medicine, confirm these consistent improvements across various infertility conditions, including premature ovarian insufficiency and polycystic ovary syndrome. The aggregate data strips away the placebo label. Adjunct acupuncture is a targeted physiological intervention that objectively supports ovarian function and embryonic development, particularly for poor responders. Translating these clinical trial results into real-world pregnancies requires strict adherence to the parameters discovered in the data. The evidence highlights a clear dose-response requirement. Casual or infrequent acupuncture fails to produce these measurable shifts. Physiological results are contingent on specific modalities like TIAS, protocols utilizing 10 or more points, and consistent session frequency. At the Berkeley Center for Reproductive Wellness, clinical protocols are built directly around this evidence, rejecting a one-size-fits-all methodology in favor of precision treatment. This evidence demands a coordinated model. The complementary practitioner must construct a custom protocol based entirely on the reproductive endocrinologist's specific IVF timeline and the patient's unique diagnostic profile. For patients facing diminished ovarian reserve or repeated IVF failures, optimizing their reproductive potential means seeking out evidence-informed, integrative care that addresses the endocrine environment as a whole.